And we're back to Chapter 2, Diseases of the Stomach. A 47-year-old male presents with a vague epigastric gnawing discomfort that occasionally awakens him from sleep. There has been no melena, hematochezia, fever, chills, or weight loss. So no alarm signs there. Past medical history includes asthma, TIA, and peptic ulcer disease many years prior. Medications are aspirin and a beclomethasone inhaler. Physical exam reveals a soft abdomen, mildly tender in the epigastrium, and an abdominal ultrasound is normal. What is the best test to evaluate this patient? Well, sounds like a mucosal problem. He also has a history of peptic ulcer disease, and the answer here is going to be do an upper endoscopy to look for an ulcer. And when you do the upper endoscopy, they find a 1 centimeter ulcer in the gastric antrum. Those are 2 ulcers there that you can see in the antrum. Those are called clean-based ulcers. And how does the management of this endoscopic finding differ from a duodenal ulcer? Well, the answer is that biopsy of the ulcers are needed to ensure that they're not malignancy. If the endoscopy showed multiple esophageal and duodenal ulcers in the second and third person, what additional tests should then be performed? Multiple ulcers all the way through from the esophagus to the third portion of the duodenum means there's so much acid. If you want to find out why there's so much acid, you check a serum gastrin level to evaluate for Zollinger-Ellison. A 45-year-old man with long history of peptic ulcer disease with sudden onset of gnawing, sharp abdominal pain that began 4 hours ago states that the pain is severe, 10 out of 10, constant, with radiation of both his shoulders, and it's associated with nausea. An X-ray shows this, and what you see is free air under the diaphragm on both sides. The only diagnosis here that makes sense is a perforated gastric ulcer. This is a surgical emergency. The most accurate test will then be a CT scan of the abdomen, followed by surgical management. If, however, going back previously, that patient comes in with the pain and the biopsy showed a MALT or mucosa-associated lymphoid tissue lymphoma, what is the best initial treatment? It turns out that MALT lymphoma is caused by H. pylori. H. pylori is a carcinogen. And so therefore, lansoprazole, amoxicillin, and clarithromycin are to be used to treat it. You treat the H. pylori, the MALT lymphoma goes away. If you check the serum gastrin on that last patient, and it turned out to be about 500, your next step in management is going to be a secretin stimulation test to see if it obeys physiology. Secretin should suppress the gastrin. If the gastrin was 1800 and they did a CAT scan of the abdomen and the contrast is negative with it, then what you want to do is you want to go ahead and look, because when it's that high, you know that it's coming from a gastrinoma, and an EUS and some octreotide scan or a somatostatin receptor scintigraphy scan will help you identify the lesion. The EUS will actually look for the pancreas and take a biopsy with a fine needle aspiration, and the octreotide scan will look for metastasis. For which of the following conditions is H. pylori treatment a proven benefit? It turns out that in duodenal ulcers, it is a proven benefit. Which of the following conditions is not a risk factor for developing a complication of NSAID-induced ulceration, meaning bleeding perfs, gastric outlet obstructions? It turns out H. pylori infection in and of itself concurrently does not put you at a higher risk of NSAID-induced ulceration. All of the other ones, however, do. In a patient in the medical ICU, which of the following disorders would be associated with a significant risk for hemorrhage, stress-related mucosal disease? In other words, which of these patients needs stress prophylaxis? And the answer is anyone who is in respiratory failure and on a mechanical ventilator needs to have a stress prophylaxis. Head injuries and burn victims also require stress injury prophylaxis, aka start empiric proton pump inhibitors. Which of the following test is the most objective means of documenting gastroparesis? That also means most objective means most accurate. And that is a nuclear medicine scintigraphy scan, aka gastric emptying study. You eat something radioactive and then we measure how long it takes to leave the stomach. If it takes longer than what's on the normogram, you have gastroparesis. And then what is the only medication FDA approved for treatment of gastroparesis? Remember, only approved. We use a lot of them. But what is approved is metoclopramide. That is the only one. True or false? Erosive gastritis is caused by NSAIDs. True or false? True. Erosive gastritis is caused by alcohol. True. Erosive gastritis is caused by smoking. False. Erosive gastritis is caused by stress. True. In which of the following situations is a PPI needed? Major surgery, burns, ventilator, head trauma, or all of the above? It turns out that all four of these is an indication for stress ulcer prophylaxis with a PPI. A 42-year-old male immigrant with peptic ulcer disease comes in. What are three commonly tested causes? Well, it turns out that H. pylori, NSAID abuse, Zollner-Ellison syndrome are the three most commonly tested. However, cancer, aka also along with Zollner-Ellison syndrome and the gastronoma, head injuries, and burn victims also develop ulcers. What three lifestyle habits prevent healing in peptic ulcer disease? Is it alcohol, diet, or smoking? It turns out that stress could do it. Which one is it? It turns out that alcohol, smoking, and stress will prevent healing. But diet has no effect on the healing of peptic ulcer disease. There's a great misnomer. A lot of you say, hey, spicy food will give you an ulcer or prevent it from healing. Listen to me. If spicy food caused ulcers or prevented them from healing, the entire country of India would be on a PPI right now. A 33-year-old female has malt lymphoma on biopsy. What we know is that means she had H. pylori. The best step in management, treat the H. pylori. It should go away. What you need to then do after 2 to 3 months of treatment is go back in and test for eradication. But you got to do that with biopsy. If the biopsies still come back with persistent malt lymphoma, the next step in management is to test for translocation 1118. That means it's a resistant form, and they're going to need resection, radiation, and possibly even chemotherapy. A 56-year-old man with upper abdominal pain without weight loss, diarrhea, change in bowel habits comes in. The exam is normal. That means that they have non-ulcer dyspepsia. If you have chronic epigastric pain with nothing else, and the exam and the endoscopy and everything is normal, it's non-ulcer dyspepsia. Also, non-ulcer dyspepsia is the most common cause of epigastric pain in the United States. What is non-ulcer dyspepsia, you ask me? You ever eat a Taco Bell and you get a little bit of, oof, what is that? That's non-ulcer dyspepsia. It's postprandial pain, discomfort, and it's functional. It's not mucosal. And the best step of management depends on the age. So for this patient, they're 56. But if they're less than 50, you start a PPI. If they're more than 50, you got to scope them, make sure there's no cancer. In this case, they're telling you there's no cancer. The answer is going to be non-ulcer dyspepsia. A 46-year-old female with upper abdominal pain without weight loss, diarrhea, change in habits. Exam is normal. EGD and biopsy are negative. No ulcers are seen. They don't improve after being on a PPI for 6 to 8 weeks for that non-ulcer dyspepsia we just saw. Look, if everything's normal, there's no mucosal problems, it's non-ulcer dyspepsia. It is the most common cause. But what if you start the PPI in someone less than 50 and they don't get better? Then, like I said, it's a functional problem, and then we can trial them on a TCA, because this is a problem with the brain-gut axis, an area that's not fully understood, but we know that with certain types of SSRIs and TCAs, we get patients relief. What are the bleeding risks for these lesions? So each one of these risks, what I want you to do is take a look at these images. They're ranging from arterial spurting to clean-based ulcers, and each one has a risk of bleeding. And here are the rates. And what you need to know is that the spurting arterial vessel will rebleed almost 90% of the time. But the clean-based ulcer will be less than or approximately 10%. And so clean-based ulcer patients, what they will ask you about is discharge planning, and they can be discharged. The remainder require further intervention. And so, ladies and gentlemen, that is the end of Diseases of the Stomach. That's Chapter 2. I'll see you in the next one. Get something to eat. Your stomach needs it.